a slight plug for an organisation in the UK called the NIHR Diagnostic Evidence Cooperatives. We are one of 4 diagnostic evidence cooperatives in the UK that will take evaluation of the diagnostic tests independently of industry, for example, and hopefully give you high quality data. It's not limited to UK industry or academia, and if any of you wish to have a chat about evaluating in future diagnostic tests, we would love to hear from you. Is the bottom line. That does mean that I work with a lot of companies.
Very hard to understand you.
Oh, sorry, I do apologise. So, ventilator-associated pneumonia, as you know, affects up to 30% of mechanically ventilated patients. It has hospital mortality of around 25%, but a debatable size of attributable mortality. It's small but real attributable mortality on top of critical illness. But 40% who survive that are dead at 1 year, typically caused by antibiotic-resistant bacteria. And perhaps the key thing to mention for the purposes of today's talk is this, that it's very, very difficult to achieve the gold standard for diagnosis in VAT, because the gold standard would be the proof of inflammation in lung tissue, infective inflammation in lung tissue. And obviously lung biopsies are not a terribly accessible opportunity on the intensive care unit. So we start off in this difficult position that we're never going to get, or very, very rarely are we ever going to get the gold standard, and therefore diagnosis is going to remain difficult. So when I talk about suspected VAT today, I'm going to be talking about mechanical ventilation for at least 48 hours, and new infiltrates on a chest x-ray, and 2 features broadly consistent with systemic inflammation, local or systemic inflammation, and pyruvate secretions. That would give us suspected VAT, but for the purposes of today, and I know this is controversial, I'm going to say that confirmed VAT requires suspected VAT plus a good quality bronchoalveolar lavage growing more than 10 to the 4 colony forming units per mil. And I know that's controversial, but it is my belief that that is the best way to make a firm diagnosis. And indeed, we had that was mandated in the lovely talk from Professor Torres before, and I have to say that what a huge achievement it is to get any trial with 400 patients with studies in VAT. It's a remarkable achievement. So how good are we with our clinical acumen at diagnosing VAT without sampling? The answer is not very good at all. This has been done by many groups, but 2 of the most esteemed groups studying VAT in the world kicked this off really. Jean-Yves Fagerholm showed initially in patients with lung infiltrates and pyruvate secretions, when they looked hard for pneumonia, they found it using very good criteria at the time in only 31% of patients. In other words, clinically wrong 70% of the time. Broadly similar studies from Umberto Meduri showed very similar findings, and this has been replicated across the literature again and again and again, that suspected VAT turns out to be confirmed VAT about 25 to 35% of the time. That's not great, because it means that we'll probably overtreat with antibiotics. So here's your big practical dilemma that you face every day, that if you're going to take, even if you do take a decent quality sample, then it's going to take 72 hours approximately to get your full cultures and the appropriate sensitivity back. And so you might start antibiotics here. Hopefully you'll start antibiotics here after the sample's been taken. Take your sample, start their antibiotics. Some people will give their antibiotics earlier or without a sample. And then you might adjust or stop your antibiotics after 3 days. There's quite good evidence to say that we don't, and that we tend to keep going for a course of 7 or 8 days, rather than stopping at 3 days and you get negative cultures. And in a perfect world, we would have diagnostic information around about here. If we could get something in the first few hours after that sample had gone, maybe we would be able to hold our nerve and not give antibiotics unless the samples return with a positive answer. So the kind of holy grail in this field is a very quick biomarker test that will give you an answer around about an hour to 6 hours after the sample has been taken. And that's what we've been pursuing for a lot of years, along with other groups and what I'm going to tell you about is a derivation study that we performed now a number of years ago. A single centre study which aimed to determine if we could distinguish true VAT from non-VAT. So in other words, take a population of patients with suspected VAT and call confirmed VAT those with a bile sample with growth of more than 10 to the 4 colony-forming units per mil. And we had 72 patients in this study. As you'll see, consistent with the literature, our VAT rate was 24%. And very briefly, the mean age was around about 55, mostly men, patchy scores around about 23, and an ICU mortality of 35%. I mentioned that only because I'll return to similar figures a little later. So we looked to see if there were any biomarkers that could distinguish the two, and in bile there appeared to be 5. And those 5 were very broadly derived from neutrophil proteases and from inflammatory cytokines produced in the lung. Interleukin-1 beta, interleukin-8, human neutrophil elastase, and matrix metalloproteinases 8 and 9, which are both neutrophil granules. Disappointingly, but this is entirely consistent with every other group that's looked, there was no signal in blood. What we really like in this field is something that distinguishes VAT from non-VAT in the blood. We are nowhere near it, and to be frank, I don't think we'll ever find it. We're going to concentrate the rest of the talk, therefore, sadly, on bile. So this was our first study, and we went on to do a validation study across the UK using 12 intensive care units. And again, I show you this information just to say that these figures are pretty much identical again. The validation study was very close in its composition, demographically and clinically, to the derivation study. We got 150 paired microbiological and biomarker results to study. And the important thing is that we were able to validate this. That maybe doesn't sound very exciting, but to the best of our knowledge, apart from one RNA study, this is the first and only, at the time this was published, this is the first and only study to validate diagnostic tests for VAT in this context, which is perhaps surprising, but it's true. What we found was that the combination of interleukin-1 beta and interleukin-8 were particularly helpful. They were both good on their own, but add them together and we could improve the chance of a rule out of VAT. So what we were aiming to do here was to push up the sensitivity to help us with a rule out test and to compromise a little the specificity. And this is what we got. These are the true negatives. In other words, the sample says there is no VAT and there was no VAT. The true positives here. What we're obviously terrified of in this setting are false negatives. What we don't want is the test to say no VAT and the patient to turn out to have VAT and be undertreated with antibiotics. So we sacrificed a number of false positives for the aim, which was to have no false negatives in this cohort. And that, as I say, was encouraging. We were anxious that sending protocolized bile out to 12 centres might not allow this result, but it did. And so, on the basis of that, we proceeded to a randomized controlled trial with a target recruitment of 211 patients, which was hard, which is why I'm so impressed by Professor Torres' 400. What we did was we took patients across 22 intensive care units in the United Kingdom and randomized them to routine care. These centres happen to perform lavage anyway, so it's not standard care. I don't think every group performs lavages, but these intensive care units were committed to lavage as part of the diagnostic algorithm for that. So either routine care or biomarker-guided discontinuation of antibiotics. In other words, if these patients came back with if the result came back saying that interleukin-1 and interleukin-8 is low, please stop antibiotics, then the clinicians in those centres were signed up to doing that on the basis of the data we saw before, where our confidence was close to 100% that there would be no VAT in those samples. Analysis was on antibiotic-free days. What we were really trying to do here was to demonstrate that we could safely reduce antibiotic use using this technique. These are data from the validation study. This is the amount of antibiotics used in the validation study. You'll see it's pretty huge. This is 0 antibiotic-free days. In other words, these patients had at least 7 days of antibiotics. So the majority of patients with suspected VAT in our validation study, the vast majority got at least 7 days. And of course, we demonstrated that the pass rate was only around 30%. And the study ran for quite some time. I am very ashamed to say that I had hoped that I'd be able to give you the results today, but in fact they are 2 months away, and we are very close to having the result. We don't have them yet, but we will be able to give the final result very shortly. This is really a thank you slide, all the slides that the places in Britain that contributed. Patients are listed here, and the people who did the work are shown in the pictures below, particularly Andrew Commore, Tom Hellier, and Caroline Kefalat. So in summary, Bala, Interleukin-1 beta and ILA do show promise for the exclusion of VAP. Whether they will alter clinical behaviour remains to be seen. As I say, this is the first validating study for biomarkers in this setting, but that doesn't mean at all that we can influence clinicians' behaviour, and that will be the key question. We've got a good test, people have the courage of their convictions to stop antibiotics, and we should be able to give those data very soon. However, the development of rapid biomarkers for conditions like VAP, where the diagnosis is complex and the gold standard effectively unattainable, is going to remain extremely challenging. And I'm afraid the absence of a blood biomarker is perhaps the most challenging thing of all in this particular sphere. Many groups working on this, but I don't think anyone's close just yet. Very final thing to say, I still think bronchoscopy has its uses. Very quick description of the most interesting data.